I Hate Politics is a podcast about a human activity we love to hate. I'm Sunil Dasgupta. Maryland's system of paying for hospital services is unique. No other state in the nation has the system despite its 50-year existence. In the 1970s, the Centers for Medicare and Medicaid Services, the federal agency that manages those programs, were concerned about the cost of hospital services rising even faster than the high inflation of the decade. And CMMS was looking for a pilot program to try to bend the trend line. Maryland was seeing one of the highest increases in the country, and it was a small, pilot-sized state. CMMS and Maryland struck an unusual and unique agreement in 1976 that created the state's all-payer system, which, different from what is known as the single-payer system, created a commission in the state to set hospital service rates for the entire state, and so subjected costs to external monitoring and control. Much like the Public Service Commission sets rates for electricity customers. The body is called the Health Services Cost Review Commission. It was agreed that the rates set by the commission would apply to all types of payers, hence the name all-payer. Now, there are 4 types of hospital patients: those who have commercial insurance, CareFirst, United Healthcare, Cigna; those that have Medicare; those that have Medicaid, and self-paying. In the other 49 states, these categories of payers pay different rates for the same service. Medicaid usually pays the least, well below what it costs hospitals to provide the service. Medicare pays more, but still below cost. Self-pay is too small a category to worry about, though what happens with uninsured folks is not a small problem. Hospitals, most of which operate as nonprofits, recoup their costs by charging commercially insured patients more. And this is then reflected in the premiums most Americans pay for commercial health insurance. The Maryland deal removed differential hospital pricing. Medicare and Medicaid paid more in Maryland, roughly $2 billion every year. But also commercially insured patients pay less. The state, by using the HSCRC to set rates, had bent the hospital cost trend line better than any other state in the union, and saved Medicare money on cost growth. You can see the shadows of this arrangement in the Obamacare logic, grouping everyone together to get lower market-wide rates, using a government commission to determine what these rates were going to be. It is important to point out that Republican administrations in Maryland have strongly defended the Maryland model, just as Democrats have. The model's biggest success lies in the buy-in from very different hospital types. Think cutting-edge work at Johns Hopkins University hospitals and the rural Washington County Hospital. One caveat to note is that all-payer does not mean all hospitals are reimbursed for services at the same rate. Johns Hopkins gets an innovation bonus that a more basic rural hospital might not be getting. But all good things come to an end. CMMS, for several years now, has been searching for a new model to include other states, bend the trend line on national hospital cost growth, and now, with the Trump administration, maybe even peg Democratic-dominant Maryland back on its preferential arrangement. In November, after months of negotiations, Maryland signed a new agreement with CMMS that will end the state's ability to negotiate Medicare rates with hospitals in the state, ending the 50-year-old all-payer arrangement. What this means for health insurance premiums and services is still being worked out. It is unclear, for example, what CMMS will pay hospitals for Medicare hospital services, which means it is unclear how much of a gap in hospital cost recovery will have to be met by commercially insured patients. To discuss the Maryland model and what is coming, I'm joined for this episode by Delegate Bonnie Cullison, Vice Chair of the Health and Government Operations Committee in the Maryland House of Delegates, and John Crum, the Executive Director of the Health Services Cost Review Commission. Stay with us.
I Hate Politics is brought to you by UMBC's Political Science program. If your goal is to make a meaningful impact with a career in local, state, or federal government, discover what this degree can do for you. Learn more at shadygrove.umbc.edu.
Walked this road about 1,000 times. You think by now we would have got it right. Broken pieces to pick up again. Cycle back to where we began. But I don't mind. Baby, I don't mind. Suffocating, but I love the home to you every time.
I Hate Politics is a podcast about our neighborhoods, workplaces, schools and streets, and our local governments as they function in diverse and democratic societies. This means our politics are messy, dirty, sometimes corrupt, with often self-serving politicians. But no matter how much we may hate politics, we are never exempt from it, even when we refuse to participate. In fact, the purpose of politics is to keep society functioning precisely when we don't agree with each other, like now. Music for this episode comes from Montgomery County native and now DC-based singer-songwriter Kara Levchenko's two new single releases, I Don't Mind and Tell Me What You Want. You can find her and her music at karalevchenko.com.
Suffocating, but I love the coming home to you every time. Like a moth drawn to a flame.
Bonnie Cullison, John Crum, welcome to I Hate Politics.
Thank you.
Thank you so much.
Maryland just renegotiated its unique agreement with the federal government for Medicare reimbursement. How is this agreement different from the old one?
The previous agreements were fairly narrow and dealt primarily with hospital services and the data from hospitals. What we're doing with the new model, called the AHEAD model, is to incorporate services beyond the hospital, preventive services, care in the community, including community workers, so that there is a much more comprehensive delivery of services to our residents.
This is a cross-subsidy model where Medicaid, Medicare, or at least the federal government, ends up paying a little bit more, and that little bit is used to be $2 billion, and that enables hospitals to agree to a lower rate from commercially insured patients. And this cross-subsidy model works because in 1976, the Center for Medicare Services, the federal government, agreed to a higher reimbursement rate for Maryland. How is that changing in the new agreement?
So it wasn't intended necessarily to be a cost subsidization. Back in the 70s, when the system was established, there was a waiver from federal rules that allowed Maryland to set rates. And because it started back then, when rates were much closer together across these different payers, you saw over time those rates get inflated at an equal rate. What that resulted in was over decades, Medicaid and Medicare paying a higher rate on a per case basis than other states, and then commercial paying lower than in other states, because in other states, the commercial insurance payments inflated much faster. However, what that waiver was predicated on was that costs couldn't exceed national cost growth. That became a priority for the federal government, very understandable. In 2014, which is really when the Maryland model converted to something that is pretty close to what we have today. The goal there was to say, okay, we're seeing these higher per case rates for Medicare in particular. We need to see some constrainment of that cost growth. So now we're going to say, okay, well, you can't grow costs as fast as the rest of the country. You have to come in at a little bit lower. And that's essentially what we're operating under today and what we'll pull through to the next agreement as well. The way that that happens, though, I think is really, really important. It's done through global budgets. And I'm happy to talk through global budgets are.
Yeah, please do.
Global budgets is a concept where you're saying to a hospital that's serving a population, there's a predicted cost to providing services for that population. We're going to cap the amount of revenue you can generate at that level. And if you can come in under those costs, then you get to keep some of that savings, and some of that savings goes back to the payers. The goal is to reduce utilization, and you can do that by preventing the need. For example, delaying the progression of chronic disease in the community. That's great. Well, that reduces the need for high acuity services. But also for services that can be done in other settings, the hospital can facilitate making sure that those services are done in those lower cost settings. So for example, a lot of what we've done here in Maryland over the past 10 years is, say, elective surgeries that can be done in a hospital, but also are appropriate to be done, in a surgery center outside of the hospital at a lower cost, or administration of infusion-based drugs.
Talk a little bit about why Maryland has had this model for 50 years. And it is only now that other states are going down that path. It's very hard to explain why that should happen. What is unique about the Maryland situation that Virginia can do it? And mind you, Virginia Medicare and Medicaid rates are lower than Maryland's. In the 70s, when this started, there were other states, for example, New Jersey, and they dropped out. What is unique about the Maryland model? And the one thing I was thinking about personally is the ability to bring hospitals together. When you say, you decide how much the budget should be for a hospital in a community, you essentially need the buy-in of the hospital to be able to have that. So is that it, or is there something else that makes the Maryland model really work while other states simply haven't been able to do it?
In order for this type of system to be successful, you have to have deep, deep partnership with hospitals and with other parts of the healthcare delivery system. They have to recognize and be willing to innovate in the ways that the model really enables. In terms of barriers for other states to come in, if you were to come in at this point in time, right, you've got to make that investment. The challenge there, right, is that you have to have a reason to make that investment if you're a state that's been in a fee-for-service model.
There's two pieces that I wanted to add, and one is the absolute commitment that Maryland legislature has to healthcare. We have led the nation in many different ways, making sure that we try to keep healthcare as affordable as possible. To some extent, we've been able to do that. For one example is our reinsurance program, which, literally lowered commercial insurance rates over a period of 7 years. And the other piece is by establishing the HSCRC, which is a unique governmental body. We said, we want to know what the results are. We want to know, we've got to see the numbers. And over 50 years, that's what we've seen. We've seen savings. We've seen improvement in some delivery of healthcare. So even, to our most vulnerable populations, we've seen the maintenance of our hospitals.
Given that the current administration, the Trump administration, is moving Maryland away from one part of the model is being removed. When you have that, what is the political support system that would allow you to continue in the Maryland model when the basis of the Maryland model is now contested?
If there's not the willingness to bring the partners together, to bring the hospitals, to bring the commercial payers,
How are they brought together?
we bring them together legislatively. We have regular meetings with the Maryland Hospital Association, regular meetings with our commercial carriers. Of course, MDH is our Medicaid. We have them at the table, and they understand that they are partners at the table, and they will challenge us because in the end, they benefit. They get to accomplish their goals, not just what their mission is, but also financially.
A hospital like Hopkins that does innovative work, that does work that almost nobody in the country does. They have to support medical education. They do a whole range of other things. Their reimbursement rate must be, really significantly higher than a community hospital out in Eastern Shore or Western Maryland. I want to understand, will they remain together under the new agreement?
I described the 10,000 foot level view of what a global budget is, but underneath that are many, many adjustments that do account for example, you mentioned graduate medical education. Well, a huge proportion of the costs of the system are for graduate medical education, residency slots, et cetera. That's a really important aspect of what hospitals do. As we develop policies to account for, let's say, GME, graduate medical education, all those hospitals are in the room and they do have voice. And we have to be able to account for different types of hospitals within those policies. So what that sometimes means is that we put things in place like benchmarking relative to your peers within the state. The other thing that we often do is we look at, are there hospital specific things that have to change? And I'll give you a really good example of that. Hospitals that have major capital projects going on. There is a policy that's been in place for a few years now within global budgets to allow them to get a hospital specific rate increase, something that's teed up over the next few months within the HSCRC is looking at a set of those innovative services that you were describing, those high acuity services, potentially carving those out of global budgets, not carving them out of rate setting, right? They have to, be done under a certain rate, but essentially saying, hey, there's some portion of this capacity that really can't be reasonably prevented, right? You can't prevent that need for high acuity services. They're largely driven by, does the technology exist to treat this type of patient that maybe couldn't have been treated in this way 5 years ago? That's a new service. Should we carve that out of the global budget, set a rate for it, and as a patient needs it, it can be delivered, right? So that is an example of an evolution of the policy that we're undertaking right now at this moment in time. Hopefully other states embark on these types of models. They recognize and build the capabilities.
Now that the new agreement said that HSCRC cannot negotiate on behalf of Medicare starting 2027, what do you think is the impact? Fundamentally, the all-payer system is gone.
I would push back on that. I think that fundamentally it's still preserving it. It's just running a different rule set for...
Okay, but you need a separate set of money to be able to continue doing that, right? Or do you think that there is a technical way to...
There's still an intent by both the federal government and the state to facilitate kind of an all-payer alignment. Will it be different than it has been? Yes, we'll have to make some changes, but really fundamentally what we're talking about here is we're still having hospital global budgets for Medicare. The federal government will set those rules. In large part, that's because they are trying to make this a multi-state model. So they have to have a set of rules that work not just for Maryland hospitals, but for hospitals in other states. But also, as a state, we're able to maintain hospital global budgets for the other payers as well. We still will have a hospital global budget environment and a payer system. What we're going to have to figure out is how do we make sure that things are coordinated between the payers in a way that still maintains that close alignment, which has been a hallmark of the Maryland model for many years. One of the things that we're working on right now is that the quality program, incentives within a hospital global budget that move revenue up and down if you hit quality target, right? That is going to be brought into alignment with the national Medicare hospital quality program. So there's a set of quality targets that any state, any hospital in any state who's participating in Medicare fee-for-service, they're incentivized to hit these quality targets. As the Medicare portion of the global budget moves in that direction, we're looking for opportunities right now to align the incentives in the other markets to align with those quality.
If Medicare and Medicaid are paying lower than what is being paid in Maryland, and that's what the rest of the states are doing, and maybe that goes up a little bit, but I doubt. If that were to happen, we are still missing money. The state is in a fiscal bind, and to fix this requires a certain amount of commitment, money commitment, to be able to maintain the all-payer system. I'm not understanding how that money deficiency is made up.
When Medicare sets the global budgets, they are going to be setting them based on historical revenue levels for the state, right? So it's not like there's going to be like a cliff, right, where revenue just drops off. So when we're talking about this quality program, we're making adjustments up and down for individual hospitals as they perform on these quality measures. That doesn't change the overall level of reimbursement for the state from Medicare.
Some of that $2 billion that CMMS is paying uniquely to Maryland will diminish. What are you expecting?
This works in largely the way that the model has worked over the last decade. There's a cost growth target. We call it the savings that the federal government and the state have to negotiate. Let's imagine hospital trend nationally for fee-for-service is increasing at 5%. And then we have a savings component that we have to hit. This is on total cost. This is not just on hospital costs. This is on all per capita costs. We have to come in at a slightly lower trend. The mechanism of cost savings and the benefit to the Medicare Trust Fund is that we're bending that cost growth slowly over time. So that's why I'm saying it's not a cliff. What we're saying is this gradual just departure from the national trend line will just continue. Over 10 years, that has resulted in quite a bit of savings, over $500 million a year for relative to national cost growth. Every year we get further from that trend line. And you want to make sure that you're getting credit for that. This is also why other states, why there's some interest in this, right? Because if you can bend your cost curve a little bit more than the rest of the country, by various ways. Maybe it's investment in primary care. Maybe it's investment in post-acute care. Your per unit costs, which is really important for the financial stability of your healthcare delivery system, can remain where it is, or even in some cases go up.
So is it your expectation that premiums for Maryland residents would not rise as a direct result of this new agreement?
So I think that remains to be seen, that this is happening within the context of a lot of other things that are putting pressure on the healthcare delivery system. I think you've seen kind of across the country, right, that individual market rates are rising. It remains to be seen. I think we have mechanisms within the model to constrain cost growth, preserve the mechanisms for promoting affordability. But
can you explain some of those mechanisms?
So we are looking at what is the right balance across the multiple markets? What is the right balance in terms of hospital rates? That will continue to be a mechanism. But there are other things as well. For a few years now, we've been managing as a state under the total cost of care model, a program that does bundled payments for physician practices. Today, it is driving savings. Does that scale up? Those savings are both happening within the hospital context as well as outside of the hospital and resulting in better quality outcomes for patients. We are enabling opportunities for innovation like that through the model I think that is where we're going to have to continue to focus and look for savings and opportunities.
On the balance issue, the balance is between commercially insured patients and the rates that they pay and the Medicare, Medicaid rates that the federal government will pay. To the extent that one of those sides may diminish by whatever that percentage is, we don't know, that balance will have to be made up on the commercially insured patient side, and that then comes out of residents' pockets. Is that logic sound?
That's sound logic.
I want to stress that there are many factors that go into setting insurance rates. This would be a factor that would have to be considered, the impact of these changes, but our annual rate review and process for our commercial carriers is a very comprehensive program that looks at many, many factors. This would just be one that would go into the mix. What we may need to be doing is looking at different allocations.
What is an example of different allocations being looked at in this context?
Medicaid is a state function. Is it, that we can make adjustments in as we have to, as well as, looking at what the share of commercial payers are. But
are you hopeful, given the fiscal situation, of the state's Medicaid allocations going up significantly to create a meaningful difference?
I'm saying that we are going to have to find a way to address it. I'm hopeful that we can find that way.
From HSCRC's perspective, our authority and our charge is to look at the cost basis for hospitals and to set rates based on those cost drivers. The broader state, inclusive of Medicaid, and certainly Vice Chair Cullison and her colleagues, and then the other regulatory agencies, and quite frankly, industry, the healthcare delivery system writ large, are going to have to wrestle with some of the bigger health economics challenges that frankly every state has.
Have you done any modeling as to the impact of the new agreement?
By and large, we are not seeing big cliffs related to the model and the savings. Now, are there things on the horizon that we are concerned about? Sure, absolutely. We're concerned about.
What is the horizon you're talking about?
5-year, 10-year, and beyond. For example, we are concerned about the aging population in Maryland, right? We are concerned about the distribution of healthcare services outside of the hospital as well. So post-acute capacity, for example, is a real stressor in some parts of the state. For example, being able to discharge a patient from the hospital. Those are things that add costs, add stressors to the system. They're not necessarily related to the model. The model can help facilitate a solution in some cases, and in some cases, it really does have to be all the regulators at the table, all of the legislators at the table.
I want to go back to the unbundling issue. We do get unbundled bills as patients. We get a bill from the doctor, we get a bill from the anesthesiologist, we get a bill from the lab, we get a radiology bill. I'd imagine the all-payer system contributed at some point to the unbundling. Maybe I'm mistaking this, so please do correct me. And that changing the rebundling it requires certain changes in the rules itself.
So I would say it is not a function of the all-payer system. It is an issue for consumers everywhere. Every state, every payer, every hospital, every physician, every practice, it deals with it on a daily basis. And then, of course, the biggest challenge is to the consumer. When I'm saying bundling, I'm really meaning the bundling of the payment to the practice for various services. That doesn't necessarily mean inherently that the billing to the patient gets solved.
Thank you for that clarification. Really appreciate it. Bonnie, are there any legislative fixes that you're already working on? Is there something we ought to be watching out for?
I'm not anticipating any legislation this year relative to it. We expect that there will be Medicaid payments. We expect that there will be Medicare payments. We don't know, how much, if they will change, and when and if, and, how we will make those adjustments. I think that's one of our focus right now, is to really make sure that we're prepared for anything that we can anticipate the federal government will do that will negatively impact us. And that was, a big part of our session in 2025, which is why we have the bills that say, vaccines are still being done in Maryland, are still being required in Maryland according to, good medical science, and that all of the benefits of the ACA, the essential benefits, are still going to be in place in Maryland.
So now that other states are looking at the Maryland model, John, are you losing people to them?
Losing staff?
Yeah.
We have a very tight-knit, dedicated group of folks here at the HSCRC, and that has not been an issue to date.
John Crum, Bonnie Cullison, thank you for taking the time to explain a supremely complex part of our modern life.
Thank you for the opportunity, Sunil. We appreciate it.
Yeah, thank you. And thank you for taking the time to engage with a really important aspect of what we are doing here in Maryland to improve affordability for Marylanders and improve the quality and access to healthcare that we all deserve.
Find me in the crowd tonight, tongue-tied. Dance with me under cotton candy skies. We can leave the pain of the past behind, lean into the moment, dancing the night away. We can have whatever we want, start a renaissance. I could be a confidant, baby, won't you tell me what you want?
That's all for this episode of I Hate Politics, where we aim to stem the decline in local news by working with community voices. Don't forget to tune in to our Tuesday morning news analysis. I Hate Politics is produced by me, Sunil Dasgupta, with support from the University of Maryland, Baltimore County. I direct UMBC's political science program at the universities at Shady Grove in Montgomery County, where, among other things, we explore and learn about politics and government and society close to home. Music for this episode comes from Montgomery County native and now DC-based singer-songwriter Kara Levchenko's two new single releases, I Don't Mind and Tell Me What You Want. You can find her and her music at karalevchenko.com. I hope you will subscribe and share the podcast as we bring you stories about politics close to you and to your home. See you next time.
Go to bed. We can watch all the colored lights again. We can leave the pain of the past behind, lean into the moment, dancing the night away. We can have whatever we want, start a renaissance. I could be a confidant. Tell me what you want.